Now we are joined by Dr. Ezra Cohen, who's Associate Director of Moores Cancer Center at University of California, San Diego Health, who will discuss some of the key data in head and neck cancer that is being presented at the 2018 ESMO Congress. Hi, Dr. Cohen. Thank you so much for being here today.
Oh, my pleasure, Gina. Thank you.
So when we met a few weeks ago, you had told me that the 2018 ESMO Congress was going to be the year of head and neck cancer. So can you kind of expand on that? What does that really mean today?
Definitely. We're seeing really important data sets for the field that are immediately practice changing. They're going to be presented at the Presidential Symposium. And not only that, we're also seeing several other abstracts that I think will portend a lot of positive steps in the future and in the near future for patients with squamous cell carcinoma of the head and neck. So we've been waiting a long time for this, and for the first time in a long time, I think head and neck cancer is really taking center stage at a major oncology conference.
So there's a lot going on, of course, yes. Keynote Oh For was one of the late-breaking abstracts. Can you discuss that study and what exactly the findings are?
Keynote Oh For was a study done in first-line recurrent and metastatic squamous cell carcinoma of the head and neck. And what I mean by that is these are patients who have had curative intent therapy, and unfortunately their cancers have progressed. And now they are candidates for treatment for recurrent or metastatic disease. And the study hypothesized that pembrolizumab, an anti-PD-1 antibody that is already approved in head and neck cancer for platinum refractory patients, the study hypothesized that pembrolizumab alone in selected patients would be better than the standard of care, which is platinum, 5-FU, and cetuximab triplet combination. And that's been the standard of care for over a decade. In addition to that, there was a second experimental arm looking at pembrolizumab in combination with chemotherapy, and again, the comparison with the extreme regimen, that triplet chemotherapy regimen. And sure enough, both the pembrolizumab alone and the pembrolizumab and chemotherapy were superior to standard of care extreme regimen. In PD-L1 expressing tumors, and it was even a low level of expression, so what we call a composite score of 1 or more, and this included 80% of the patients, pembrolizumab alone demonstrated superior overall survival to the extreme regimen. And now I think represents the new standard of care in tumors that express PD-L1. In all comers, irrespective of PD-L1 status, pembrolizumab and chemotherapy was superior in overall survival to the extreme regimen, and now represents a new standard of care in recurrent metastatic disease for patients irrespective of PD-L1 expression. So this is an incredibly positive step. It's really a way in many patients, we're talking about the majority of our patients, to treat them and eliminate the toxicity of chemotherapy while improving overall survival. It's really incredible.
Good, great. Those are some great points. Now, how about the Deescalate trial that was presented with cetuximab?
Well, Deescalate is an important now negative study. And what I mean by that is that Deescalate was set up in patients who are HPV positive, being treated for locally advanced disease in the curative setting. So these are patients that we think that we can cure of locally advanced head and neck cancer. We know that the HPV positive population is a better prognosis population. And so the thought was that we could take that better prognosis population, substitute cetuximab for cisplatin, offer a less toxic regimen, and maintain the cure rates for those good prognosis patients. Well, it turns out that neither was true. Cetuximab appears to be just as toxic as cisplatin radiation. It's different toxicity, but in terms of the degree of toxicity and the rates of toxicity, it was the same. But more importantly, cetuximab offered inferior survival. And in patients that we're trying to cure, that becomes paramount. And so it's an important negative study because it tells the field that as of right now, even for those good prognosis patients, cisplatin radiation is still the standard of care. It also tells us that we do need to be careful when we're thinking about de-escalation strategies, even in good prognosis patients. We have to be methodical, we have to be systematic, and we eventually have to do those phase 3 studies to prove the point. because what we think might be better sometimes doesn't turn out to be.
Very true. Okay. Now, you are also authored on the SCORE study of durvalumab plus danvatirsen, or AZD 5069, in advanced solid malignancies and recurrent metastatic disease. So what's the background of this trial and what are the early findings?
The study really attempted to augment the activity of existing immunotherapy, and that is an anti-PD-1 or anti-PD-L1 antibody. In this case, it was durvalumab, which is an anti-PD-L1 antibody. And we know in head and neck cancer that one of the major mechanisms of immunosuppression are the white cells in the tumor microenvironment, especially the macrophages. We also know that STAT3 is an important signaling molecule for those cells. Well, danvatirsen is a STAT3 oligonucleotide that preferentially gets into these immune cells and clearly inhibits STAT3 function. So we thought that if we could do that in cancers in combination with a PD-L1 antibody, we would be able to improve response rates, and that's exactly what we saw. In fact, what we're seeing is about a doubling of the response rate with, as opposed to durvalumab alone. And those responses not only are higher in number, but many of them are complete responses, suggesting that we may be able to get in some patients dramatic efficacy and prolonged durable responses, and that's exactly what we're beginning to see, and that's exactly what we reported in ESMO 2018. And the nice thing about the study is that we can do it without increasing the toxicity. We saw some toxicity with the addition of the STAT3 oligo, but all of those were minor and reversible. So here we have an opportunity to improve the efficacy without dramatically changing the toxicity. And as you can guess, we're now beginning to think of larger trials and taking this regimen forward.
That's great. Sounds like it has a lot of potential.
I think so.
So what are some other trials being presented here in head and neck cancer that you're really excited about?
And again, I'll reiterate that this really is a great year for head and neck cancer at ESMO. And some of the other studies are all early trials, but demonstrating that we may be able to really improve the efficacy of immunotherapy. One such study is combining pembrolizumab with a drug called SD101. That is an injectable, so intratumoral injection of a toll-like receptor 9 agonist. And what we saw was about a doubling of response rate compared to pembrolizumab alone, not only in the targeted lesions, but also in the lesions that were not injected, suggesting that this drug can produce a systemic effect that augments anti-PD-1 activity. And again, that's something that needs to mature, but looks very promising at this point. Two other studies that are worth mentioning, one of them specifically in HPV-positive patients across the board, not only in head and neck cancer, but HPV-positive cervical and anal cancers, a drug called M7824 that is a dual inhibitor of PD-L1 and TGF-beta. And we've known that in virally induced cancers, TGF-beta is an important mechanism of immunosuppression. And what effectively this drug does is it brings the agent to the tumor because of PD-L1 and to that immune interface, inhibits TGF-beta in addition to PD-L1. And what we're seeing in HPV-positive cancers is a response rate over 30%, wow, which is profoundly higher than what PD-L1 alone does. Still early days, still small numbers, but if this turns out to be true in larger cohorts, this would be an incredibly large step for HPV-positive cancers. And then lastly, I'll mention an agent that doesn't involve PD-1 in head and neck cancer, and that is monalizumab. This is a drug that targets primarily natural killer cells, or NK cells, an important receptor on NK cells that negatively regulates their function is called NKG2R, and monalizumab inhibits the function of that receptor, and in combination with cetuximab, which is what the phase 2 study did, what we saw was about a doubling of response rate compared to cetuximab alone in a single arm, but a response rate of about 30%. And certainly, again, something that is exciting, and we will look forward to larger data sets in the near future.
Oh, great. So let's fast forward 1 year from now. What do you think the landscape of head and neck cancer treatment looks like to you?
Well, I think from a year from now, we'll certainly have pembrolizumab as an accepted first-line therapy in recurrent metastatic disease. As I mentioned, for PD-L1 expressing tumors, I think it'll be pembrolizumab alone. For the others, it'll be pembrolizumab and chemotherapy. I don't think we'll have other mature data sets a year from now that will change the standard of care, but we'll be close. We're anticipating the data of PD-1 and CTLA-4. The Checkmate 651 study of nivolumab and ipilimumab may be mature a year from now, and that may influence what we do for first-line recurrent metastatic patients. And the other thing that we'll see is that in the locally advanced setting, we'll see more and more data about the safety of these drugs in combination with radiation and with chemotherapy radiation. The larger phase 3 trials will take a little bit longer to report, but I think a year from now we will feel very secure that it is safe to combine anti-PD-1 in the curative locally advanced setting with chemotherapy radiation, and of course that will lead to hopefully a change in the standard of care eventually for locally advanced disease.
Good. Well, that was amazing. Thank you so much for being here today and
Thanks,
sharing your
Jen.
insight on all these abstracts.
Always my pleasure. Thank you very much.
Thank you.